Hello everyone. Today we will be talking about pharmacogenomics and pharmacogenetics. Now, what is the basic difference? Pharmacogenetics mainly deals with genetic influence on drug, whereas pharmacogenomics is study of genetic makeup of the individual for better treatment. What I mean by this, we will understand with an example. Let us say there is a patient, he has underwent his genetic analysis and came to know that he responds best to certain drug A. Based on these results, clinician will treat him for the disease with drug A, so that better therapy is there, better treatment will be available. Whereas with respect to pharmacogenetics, let us say there is a patient, he is treated, he has some issue and he is treated with a drug. Okay, and for the drug, the patient has shown an abnormal response, not something normal. Now, what the clinician does is he starts understanding the genetic makeup of the individual to understand why this abnormal response is present. So, pharmacogenetics is primarily a retrospective thing. After seeing the response of the drug, then we will go for your genetic assess. And usually, pharmacogenomics is also called as personalized therapy because we are understanding the genetic makeup and we are going for treatment. Clear? Now, all these happen primarily because of single nucleotide polymorphisms, and these single nucleotide polymorphisms can result in either pharmacokinetic changes, that is, changes in the level of absorption, distribution, metabolism, and excretion, or pharmacodynamic changes like changes at the level of receptor expression, or some your enzymes which are modulated by these drugs expression and all. Clear. We understand pharmacogenomics primarily with certain examples. One such example is acetylation. Acetylation is a phase 2, is a part and parcel of phase 2 biotransformation reaction. If N is mediated by NAT2 gene, this NAT2 gene is responsible for expressing the enzyme N-acetyl transferase. When N-acetyl transferase is present, what happens is this is responsible for metabolism of the drugs. Drugs which show acetylation include SHIP group of drugs. S stands for sulfur groups, H stands for hydralazine, I stands for isoniazid, P stands for periodic acid shift, that is your PAS, as well as, and what happens is, let us take an example of isoniazid. Isoniazid is basically an anti-tubercular drug. Let us say if patient is expressing more of N-acetyl transferase, there will be more metabolism of your isoniazid, resulting in treatment failure. That is, whether your tuberculosis is treated or not, it will not be treated. If there is less expression of N-acetyl transferase, then there will be less metabolism, resulting in lot of side effects. Most prominent side effect is peripheral neuropathy. So, DOTS patients, we usually supplement them with pyridoxine to prevent this peripheral neuropathy. Am I clear? This is your first example, and in fact very important example. Then followed by, see, usually succinylcholine, which is a muscle relaxant, is metabolized by pseudocholinesterase. This pseudocholinesterase has two main functions. One is metabolism of choline, acetylcholine in the GIT, as well as metabolism of succinylcholine. Clear? Okay. Now, some patients show atypical pseudocholinesterase, because of which succinylcholine metabolism will be delayed. So, there will be prolonged muscle relaxation. So, muscle relaxation will be for longer periods. This prolonged muscle relaxation results in prolonged apnea. So, a patient who has abnormal atypical pseudocholinesterase will be intubated, where the extubation will be delayed. Clear? Now, third example is G6PD deficiency. This we have read right from our biochem. Glucose 6-phosphate dehydrogenase deficiency patients, if they are treated with sulfur group of drugs or quinine group of drugs like your antimalarials, patient ends up with dangerous hemolysis. Clear? Now, then comes our next example, halothane. which is basically a inhalational general anesthetic. Patient has abnormal ryanodine receptors, because of which some patients who have abnormal ryanodine receptors, when given halothane, ends up with malignant hyperthermia. This malignant hyperthermia is primarily because of increased calcium release, increased calcium release from sarcoplasmic endoplasmic reticulum. So how do you treat this? We treat this with dantrolene. Clear? Now, then let us talk about our fifth example. Patients who are on azathioprine or 6-mercaptopurine, they usually, azathioprine to get activated, it needs thiopurine methyl transferase enzyme. Now, this thiopurine methyl transferase enzyme, if the expression is more, it will lead to more action of azathioprine. So, more action resulting in more of opportunistic infections, more immunosuppression, so more opportunistic infections. Whereas if TPMT is less, this results in therapeutic failure. Okay, now these all are very important. Okay, now in the same way, acute intermittent porphyria, acute intermittent porphyria is seen for a patient who are on barbiturates because of genetic defects mainly in porphyrin synthesis. This also we have read in your biochem. Genetic defects mainly in porphyrin synthesis. Clear? In the same way, we need to understand CYP2C9, cytochrome P2C9, as well as vitamin K oxidoreductase enzyme. Both, this is expressed by C1 gene. Okay, both are responsible for warfarin action differences. There can be either toxicity or anticoagulant failure. Now, we need to understand certain recent advances also. Most importantly, with respect to oncology, until and unless a breast cancer is positive for estrogen receptors, HER2 positive, we don't treat them with trastuzumab. Yes, this is the typical personalized therapy example. In the same way, BCR ABL gene positive CML only will be treated, positive CML only will be treated with your imatinib mesylate. In the same way, we need to understand certain other recent advances also in this, not so recent but important, because CYP2C19 variations are responsible for understanding the clopidogrel efficiency. So, if CYP2C19 is present more, clopidogrel will be metabolized more, because of which antiplatelet efficacy failure will be present. If CYP2C19 is present less, so there will be less metabolism and more side effects, and most important is increased bleeding tendencies. In the same way, we need to understand abacavir. Abacavir is an antiviral drug. With respect to this, patients who are positive for HLA-B5701 gene, they show more hypersensitivity. In fact, life-threatening hypersensitivity will be seen with them, for them. I think with this we can stop pharmacogenomics. Thank you for patient listening.